You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about carotid artery stenosis. We'll go over the definition, diagnosis, and presentation of carotid artery stenosis, medical management, intervention, and then cover a few points on related carotid diseases. Let's start with the presentation. Internal carotid artery is the one that goes to the brain. External carotid artery supplies the face and scalp. What does symptomatic carotid artery disease mean? It refers to patients who have either non-disabling stroke or TIA within the last 6 months. Non-disabling stroke is defined as residual deficit associated with a score of 2 or less according to the modified Rankin scale. Transient cerebral ischemic symptoms can include ipsilateral amaurosis fugax, contralateral motor sensory symptoms, or aphasia. Contrary to popular belief, dizziness, presyncope, and syncope do not count as symptomatic carotid artery stenosis. You're not supposed to order a carotid duplex ultrasound in an asymptomatic patient with no risk factors. You are allowed to order carotid duplex ultrasound pre-CABG if the patient has any of the following: age more than 65, left main coronary artery stenosis, peripheral artery disease, history of smoking, history of stroke or TIA, or carotid bruit. On ultrasound of the carotid arteries, a peak systolic velocity of 180 centimeters or more corresponds to a stenosis of 50% or more, which is moderate stenosis. A peak systolic velocity of 230 centimeters per second or more corresponds to a stenosis of 70% or more, which is severe stenosis. 0 to 49% stenosis is considered mild stenosis. If a patient has a carotid artery occlusion that is a 100% blockage, the peak systolic velocity measured by ultrasound in the contralateral carotid artery may be falsely elevated due to collateral flow, leading to overestimation of the stenosis severity. Other than ultrasound, you can do CT angiography and MR angiography of the aortic arch, great vessels, distal ICA, and intracranial vessels. If there is a bruit or if there are symptoms, you need to do the CTA or MRA, not just the ultrasound. In terms of medical management, all carotid stenosis gets medical therapy. If it's asymptomatic carotid stenosis, aspirin alone is fine. If it's symptomatic carotid stenosis, you'll want to do DAPT, meaning aspirin and clopidogrel, for up to 90 days after the minor stroke or high-risk TIA, followed by aspirin alone. In terms of intervention, unfortunately, the AHA-ACC guidelines on this topic are extremely old. At the time of recording in 2024, the most recent AHA-ACC guidelines on carotid artery disease are from 2011. The 2011 guideline on the management of patients with extracranial carotid and vertebral artery disease. Therefore, I will supplement this episode with the recommendations from the newer 2022 Society for Vascular Surgery Clinical Practice Guidelines for Management of Extracranial Cerebrovascular Disease. First, can you intervene in patients with severe stenosis of the carotid artery that's symptomatic? That one, definitely, since it's symptomatic. If symptomatic, meaning TIA or ischemic stroke in the distribution of the affected vessel within the past 6 months, at least 50% stenosis by catheter angiography or at least 70% stenosis by non-invasive imaging such as ultrasound, then you can intervene by CEA or by CAS, carotid endarterectomy or carotid artery stenting. The 2011 AHA-ACC guidelines say patients at average or low surgical risk who experience non-disabling ischemic stroke or transient cerebral ischemic symptoms, including hemispheric events or amaurosis fugax within 6 months, should undergo carotid endarterectomy if the diameter of the lumen of the ipsilateral internal carotid artery is reduced by more than 70% as documented by non-invasive imaging such as ultrasound, or more than 50% as documented by catheter angiography, and the anticipated rate of perioperative stroke or mortality is less than 6%. That is a class 1 recommendation. They also say that carotid artery Stenting is indicated as an alternative to carotid endarterectomy for symptomatic patients at average or low risk of complications associated with endovascular intervention when the diameter of the lumen of the internal carotid artery is reduced by more than 70% as documented by non-invasive imaging or more than 50% as documented by catheter angiography, and the anticipated rate of periprocedural stroke or mortality is less than 6%, Class 1. The 2022 SVS guidelines from the surgeons say pretty much the same thing, although they explicitly say we recommend carotid endarterectomy over carotid artery stenting in low and standard risk patients with more than 50% symptomatic carotid artery stenosis. That's a Class 1 recommendation from them. In symptomatic carotid artery stenosis, the stroke risk increases with a percent stenosis, as expected. The greatest benefit occurs in the following symptomatic patients: the elderly, that's an ARR of 19%, absolute risk reduction of 19% in more than 75-year-olds compared to 6% in less than 65-year-olds. Recent symptoms, an ARR of 19% if treated within 2 weeks compared to 0.8% ARR if more than 12 weeks of symptoms, 12 weeks after symptoms. Males, ARR of 11% of male compared to 3% of male, and hemispheric symptoms, an ARR of 18% of stroke, 15% of TIA, and 5% of amaurosis fugax. Therefore, you really need to revascularize soon after the TIA or non-disabling stroke. When should you do it? I.e., how long after the stroke do you have to wait before doing it? Regarding the timing, the 2011 AHA-ACC guidelines say when revascularization is indicated for patients with TIA, or stroke, and there are no contraindications to early revascularization, intervention within 2 weeks of the index event is reasonable rather than delaying surgery, Class 2A. According to the 2022 SVS guidelines, in patients with recent stable stroke modified Rankin scale score 0 to 2, we recommend carotid revascularization for symptomatic patients with more than 50% stenosis to be performed as soon as the patient is neurologically stable, after 48 hours, but definitely before 14 days after the onset of symptoms, Class 1 recommendation. So both the 2011 AHA-ACC and the 2022 SVS guidelines say that you definitely need to do the revascularization within 2 weeks of the stroke or TIA, but the SVS guidelines add the helpful caveat that the patient needs to be neurologically stable and after 48 hours first. The 2022 SVS guidelines also offer a tidbit about situations where you shouldn't revascularize in a setting of stroke. They say, we recommend against revascularization, regardless of the extent of stenosis, for patients who experience a disabling stroke, have a modified Rankin scale score of at least 3 or higher, whose area of infarction is more than 30% of the ipsilateral middle cerebral artery territory, or who have altered consciousness to minimize the risk of postoperative parenchymal hemorrhage. These patients can be re-evaluated for revascularization later if their neurologic recovery is satisfactory. I omitted the class of recommendation here because they put grade 1, which is different from the system in the AHA-ACC uses, where this would be considered a class 3 recommendation for harm. And so it's a slightly different system. I don't want to confuse anyone. For non-severe stenosis of carotid arteries, of course, everyone agrees that intervention should not be done for less than 50% stenosis. In their wording, they say, except in extraordinary circumstances, carotid revascularization by either CEA or CAS is not recommended when atherosclerosis narrows the lumen by less than 50%. Class 3, no benefit from AHA-ACC. What about severe stenosis of the carotid artery that is asymptomatic? What to do in asymptomatic severe CAS? The data is mixed, but is starting to tip towards intervention. The 2011 AHA-ACC guidelines are quite non-committal about intervening in asymptomatic patients. They say selection of asymptomatic patients for carotid revascularization should be guided by an assessment of comorbid conditions, life expectancy, and other individual factors, and should include a thorough discussion of the risks and benefits of the procedure with an understanding of patient preferences, Class 1 indication. It is reasonable to perform CEA, carotid endarterectomy, in asymptomatic patients who have more than 70% stenosis of the internal carotid artery if the risk of perioperative stroke, MI, and death is low, Class 2A. The 2022 SBS guidelines go further and say for low surgical risk patients with asymptomatic carotid bifurcation atherosclerosis and stenosis of more than 70%, documented by validated duplex ultrasound or CTA angiography, we recommend carotid endarterectomy with best medical therapy instead of maximal medical therapy alone for the long-term prevention of stroke and death, Class 1. Some clinical or imaging high-risk features on asymptomatic carotid stenosis patients that might prompt intervention are as follows: silent ipsilateral stroke on CT, progression more than 20%, plaque characteristics such as area, juxtaluminal black area, hemorrhage or lucency on ultrasound, contralateral TIA or stroke, impaired cerebral vascular reserve, and microembolic signals on transcranial Doppler. So, should you do carotid endarterectomy surgery or carotid artery stenting? According to the 2011 carotid artery guidelines, it is reasonable to choose carotid endarterectomy over carotid artery stenting when revascularization is indicated in older patients, particularly when arterial pathoanatomy is unfavorable for endovascular intervention, Class 2A. It is reasonable to choose carotid artery stenosis over carotid endarterectomy when revascularization is indicated in patients with neck anatomy unfavorable for arterial surgery, Class 2A. Conditions that produce unfavorable neck anatomy include, but are not limited to, arterial stenosis distal to the second cervical vertebra or proximal intrathoracic arterial stenosis, previous ipsilateral carotid endarterectomy, contralateral vocal cord paralysis, open tracheostomy, radical surgery, and irradiation. Carotid endarterectomy causes more cranial nerve palsy in 5% and more MI. Carotid stenting, on the other hand, causes more perioperative stroke, but the late stroke risk is similar to that of CEA. Overall, CEA, carotid endarterectomy, seems to have the overall edge over carotid artery stenting, especially in older patients. They keep emphasizing risk of complications, which is non-negligible in both CEA and CES. So, per the 2011 AHA-ACC guidelines, in symptomatic or asymptomatic patients at high risk of complications for carotid revascularization by either CEA or CAS because of comorbidities, the effectiveness of revascularization versus medical therapy alone is not well established, Class 2B. Comorbidities that increase the risk of revascularization include, but are not limited to, age more than 80 years, New York Heart Association Class 3 or 4 heart failure, LV ejection fraction less than 30%, Class 3 or 4 angina pectoris, left main or multivessel CAD, need for cardiac surgery within 30 days, MI within 4 weeks, and severe chronic lung disease. Regarding chronic total occlusion of the carotid artery, there is no role for revascularizing CTO of the carotid artery, even if it was associated with a stroke. The guidelines say just that. Carotid revascularization is not recommended for patients with chronic total occlusion of the targeted carotid artery. Class 3, no benefit. TCAR is transcarotid artery revascularization that avoids the aortic arch. You can use an external temporary AV shunt carotid to femoral vein to reverse carotid flow during stenting, so the risk of stroke is very low. It was approved by the FDA in 2015, but there has been no proper randomized comparison. I don't really think you need to know about that. Of course, for all carotid artery stenosis, smoking cessation should be attempted. The 2011 AHA-ACC ASA guidelines for carotid artery stenosis say patients with extracranial carotid or vertebral atherosclerosis who smoke cigarettes should be advised to quit smoking and be offered smoking cessation interventions to reduce the risk of atherosclerosis progression and stroke. That is a Class 1 recommendation. A few other carotid artery things. Carotid artery dissection would cause pain, Horner syndrome, which involves ptosis and meiosis, and ischemic syndromes. There are no RCTs of intervention for carotid artery dissection, unfortunately. Carotid FMD. Carotid FMD is the second most common location of FMD after renal artery fibromuscular dysplasia and is associated with SCAD, spontaneous coronary artery dissection. It can be asymptomatic or cause pulsatile tinnitus, headache, or TI or stroke. There's no procedural intervention for carotid fibromuscular dysplasia. You just give antiplatelets and blood pressure control. That is everything that I wanted to tell you about carotid artery disease.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.